Non-Statin Therapies for Dyslipidemia, Insight onto Hypertriglyceridemia. Here is Dr. Arunachalam Isakyapan, Senior Interventional and Cardiologist, Aruna Cardiac Center, Nellai. So he is a former consultant at Apollo Hospital, Secunderabad. He is an expert in coronary and vascular intervention, implanting pacemakers, IVS and FFR. Now over to you, sir.
Good morning, everybody. First of all, I thank Dr. Calwin for giving me this opportunity to share my view among this august audience, this non-statin therapies in dyslipidemia. Actually, the people, we mostly dealt with the effect of CAD. He has made to think about the cause. And so if you see that all the American College of Cardiology and AHA recommendations for non-statin therapies, it is they classified broadly under three groups. Either they have less statin response in spite of full dose statin, or the patients who are not able to tolerate even a moderate intensity statin, or those who are totally intolerant to statins. These are the three scenarios commonly we come across. Let me start with a molecule which is making a big thing among the pharma industry and interventional cardiology, inclisiran. As the previous speaker was stating that this is a small interfering RNA molecule, has a sense-antisense strength, which enters into the hepatocyte and forms a, along with the silencing complex, make this risk. This risk, what happens is, this combines with the PCSK9 mRNA. So, and prevents the translation. PCSK9 is a protein which actually reduces the LDL receptor. That is, if this PCSK9 binds to the LDL receptor and degrades it intracellularly in the endolysosomes. So, by preventing this PCSK9 production by means of this small interfering RNA, so this, what happens is, this prevents this siRNA, this inclisiran prevents PCSK9 mRNA translation. It silences the translation and thereby the production of the protein. So when this protein has come down, it will not produce much LDL receptor lowering. So LDL receptor levels will start increasing, more recycling, more LDL receptor will be there. So it will take more LDL and thereby it reduces the LDL levels more potently, mostly 50 to 55% from the baseline. So this is what, if somebody wants to know what is this PCSK9, it is pro-protein convertase subtilin kexin 9 protein which is present in the liver, and that by it, the mechanism was already stated. It is a single injection given subcutaneously, and the reduction is at the rate of 2% per month. And now the current recommendation, it is approved by US FDA in 2021, and it is given at day 1 and at 90 days, that is 3 months and 6 months, and thereafter it is given every 6 months. That's a big advantage for those who are not properly on drugs or statin intolerant. And if you see that the trials have clearly said that it is on par equal to high intensity full dose statin of 40 milligram of rosuvastatin or 80 or slightly more than that. And all the regimens have found very minimal adverse effects when compared to the placebo. When you come to the LOFT trials with Orion trials, this Orion 10 trial has reduced LDL by 56% and Orion 3 this. But currently the cardiovascular outcome trials are only 2 trials. They are yet to complete by 2025 and 2027. And the mean reduction is almost 50%. Again, coming to the safety, no much adverse effects. You get the subcutaneous site reactions and non-specific reactions like a nasopharyngitis and this gastrointestinal upset very rarely, and no much drug-drug interaction with statin. That's a fantastic one. So it can be added to the statin if the reduction is not satisfactory, LDL reduction. And the dosage is 284 milligram given subcutaneously, as I said, on day 1, 3 months, and then every 6 months. These are all the two fantastic trials yet to come, Orion 4 and Victorian 2P. These are the two trials, the cardiovascular outcome trials, especially with the reduction of ACS, MI, stroke, and cardiovascular death yet to come. Coming to the next drug, bempedoic acid, and now this is one comparing inclisiran, which costs more than $1 lakh. This is the one another promising drug. If then high dose statin is not able to does it work. So the bempedoic acid is a prodrug. So it gets activated by the long chain acyl-CoA synthase A, which is present in the liver. So that is the thing. This doesn't have much. This enzyme is not present in the muscle. That is what you don't get much myopathy issues with this bempedoic acid. And we all know that statin, the basic mechanism of action is HMG-CoA reductase inhibitor, which is on the way of synthesis of cholesterol pathway. This drug acts a step ahead of HMG-CoA reductase enzyme. That is called ATP citrate lyase enzyme, ACL. So what happens is this ACL enzyme gets inhibited, and so the cholesterol synthesis is reduced. When the cholesterol synthesis is reduced, LDL receptor gets upgraded, and thereby more LDL is taken up and degraded. So this cartoon says that, see, this is the citrate plus CoA, which gets converted by this ATP citrate lyase to acyl-CoA, which gets converted by HMG-CoA reductase to cholesterol. And this is the cholesterol synthesis in short. So you all know the statin, everybody know HMG-CoA reductase inhibitor. A step ahead of that, the bempedoic acid acts and reduces the cholesterol level and upregulates the LDL, which takes up the more of LDL. As also you see this LDL receptor as inclisiran, I was saying that this is a PCSK mRNA inhibitor. And so now the terminology has been changed. You are not supposed to say PCSK9 inhibitors. You should say that evolocumab, alirocumab as PCSK9 monoclonal antibodies, because inclisiran also inhibits PCSK9. So what they changed the terminology, this alirocumab and evolocumab, evinocumab as monoclonal antibodies, and this prevents intracellular PCSK9. This is extracellular PCSK9 inhibitors, monoclonal antibodies. Even though the mechanism is different, finally it prevents the LDL receptor degradation, and finally the upregulation of LDL, and the LDL is more taken off and cleared from the blood. And if you see that it is highly plasma protein bound, and the mean achievement, median time of achievement is 3.5 hours, and the half-life is somewhere between 15 to 24 hours. And the studies were not much robust studies supporting that. The harmony is controversial, and wisdom studies, there is significant reduction of total cholesterol ApoB in a non-HDL HSCRP, and Serenity trial supports along with that reduction of HSCRP. By safety wise, it's no myopathies. Most commonly reported side effects are nasopharyngitis, URI, and non-specific arthralgia and diarrhea. The one caution is this, of course, in India, we don't much use Simva and Pravastatin compared to the European and other countries. We use mostly Atorva and Rosuvastatin, so that's not a much issue in our country. But if you are going to combine with Simva or Pravastatin, the dose should be 20 for Simvastatin and 40 for Pravastatin. One concern with this molecule is it decreases the hemoglobin level and leukocyte count, and there is a caution with BPH and tendon rupture, not much significant in the studies. The dose is, you all know that it's a 180 milligram once a day dose, can be combined with statins and also with ezetimibe. And then comes this extracellular PCSK9 blocker, or called as monoclonal antibodies. As previously said, that the PCSK9 enzyme is LDL regulation. This binds to the LDL receptors on hepatocytes, and you know that the main function of the LDL receptor is to remove the LDL from the circulation, and thereby preventing the LDL deposition in the peripheral tissues. what happens is this: when this PCSK9 is a protein which combines with the LDL and promotes the LDL receptor degradation and thereby increases LDL. So this blockers, monoclonal antibodies block this enzyme, prevents LDL receptor downregulation, make it sub. This cartoon will tell that. This is the normal LDL degradation pathway. You can see that this is LDL and this Y is the LDL receptor. So the LDL binds to the receptor, it goes into the endosome, lysosome, where LDL is degraded, but the receptor is recycled to pick up more LDL. What happens with this PCSK9? This is the protein, as I said that. So what happens is when this complex is formed along with the LDL, LDL receptor and PCSK9, when this goes it, unfortunately instead of the unwanted effect, it degrades the LDL receptor more than LDL. So less LDL receptor is come to the surface for picking up the LDL. So what this PCSK9 monoclonal antibody does is this prevents this PCSK9 binding to this complex and thereby prevents LDL degradation. So more LDL receptor gets recycled and thereby LDL reduction occurs. And almost there is 60% reduction of LDL just within days, and so the effect is maintained for 2 weeks. That is why the dose is for PCSK9 monoclonal antibodies every 2 weeks. And it is a concentration dependent mechanism of blocking the extracellularly PCSK9. So one point when saturation occurs, there is no much effect of increasing the dose of this evolocumab or alirocumab, but what happens is the action occurs for a period, more period. The duration of action is extended 2 weeks, so that's a benefit. So there are, initially it was only indicated for homozygous familial hypercholesterolemia, but now also for the atherosclerotic cardiovascular event secondary prevention it is there. So alirocumab is the first drug which was approved in July 2015, and a short month, 2 months, evolocumab came. But this bosocimab has a problem with immunogenicity and taken out from the market. And alirocumab, the support comes from the Odyssey trial. It significantly reduced the MACE events, and you can see that the reduction at 24 weeks for ApoB, non-HDL, and as stated by the previous speaker, and lipo-A also following alirocumab treatment. The dosage of this is 75 milligram every 2 weeks or 150 milligram every 2 weeks can be given, or the other way it is a 300 mg subcutaneously every 4 weeks. And not much side effects except for the site reactions, injection site reactions. And evolocumab, you all know that it's 150 milligram every 2 weeks or 420 milligram every 4 weeks. It's supported hugely by 27,564 patients enrolled in the trial, 4-year trial, which has said that there is a reduction of in patients who are already had a MI or a stroke or a peripheral arterial disease with atorvastatin 20 milligram of more than 20 milligram atorvastatin, and there was a clear reduction of cardiovascular death, MI, stroke or revascularization. And this is another newer drug, evinocumab. Those alirocumab and evolocumab acts at PCSK9 extracellular binding. This is a newer molecule which acts independent of LDL receptor. There is nothing to do with LDL receptor. It acts at a protein called angiopoietin-like protein 3. It binds to and inhibits that. What this protein does is, this is a protein which is secreted and expressed in liver, and this protein, this ANGPTL3 protein, inhibits lipoprotein lipase and endothelial lipase. These are the two enzymes which are crucial in lipoprotein metabolism, which leads to increase in triglycerides, LDL and other lipids. So what happens is, they have found the variants who lack genetically this protein, or if this evinocumab is given, when this inhibits this protein and the enzyme inhibition is released, and this leads to increased VLDL processing. You know that VLDL is the storage, endogenous triglyceride storage, and chylomicron is the exogenous triglyceride storage. So VLDL gets converted into the finally to all the LDL, IDL, LDL. So finally it increases the processing of VLDL and thereby reduces triglyceride, LDL and other lipids in the blood. So that FDA approved, it's only for currently for homozygous familial hypercholesterolemia, and in pediatric patients also the dose is 15 mg per kg given as every 4 weeks as IV infusion. All others are given as subcutaneous, this is IV. And the mean reduction is 49%, no much side effects except for influenza-like illness, nasopharyngitis, rhinorrhea and nausea. And again, the safety is pretty good, only the injection site reactions, but no data have demonstrated an increased rate of diabetes and PCSK9 monoclonal antibodies. And one other thing, as previous speaker was stating, that this PCSK9 protein is closely associated with C-reactive protein, fibrinogen, and all the inflammatory mediators associated with CAD and peripheral arterial disease and stroke. So it's presumed that this, by blocking this PCSK9, all the CRP levels and all the inflammatory levels are brought down. And the lower the LDL level achieved with either PCSK antibody are associated clearly with cardiovascular risk reduction in high-risk patients and very high-risk patients, and moreover it can be topped up with high-dose statins also, no much drug-drug interaction with statins. Coming to lometapide, this is another drug which directly binds to MTP protein, that is microsomal triglyceride transfer protein, which resides in endoplasmic reticulum of the hepatocytes. And this next slide will tell that. So these MTP proteins, these triglycerides are converted. This is what I was saying, that this chylomicrons, exogenous triglycerides converted by MTP into VLDL, which gets converted into lipoprotein lipase to LDL and all the things. So what happens, this MTP, this is inhibited by lometapide, and what happens is it reduces all the levels, say LDL, ApoB, non-HDL in familial homozygous familial hypercholesterolemia. And the dose and route of administration, it is a 5 milligram oral dose. You can titrate every 2 to 4 weeks up to 20, 40 and 60 milligram, and the mean LDL reduction is very satisfactory, up to 50%. But currently the recommendation is not for secondary prevention of ASVD, it's only for homozygous FH. And the side effects are not much except for GI side effects. But one thing you must recall, your all entrance examination questions 20, 25 years back, all the liver interaction is there. See, cytochrome 3A inhibitor, avoiding the grape juice, or rifampicin, estrogens, oral contraceptives, atorvastatin, P-glycoprotein, all these drug-drug interactions, like what you remember with warfarin, you are supposed to remember with lometapide. And coming to ezetimibe, this is one cheap and best cost-effective drug which everybody should use it along with statins, with full dose statin or half dose statin if the patient is not tolerating. And the industry is now, all the pharma industries with ezetimibe, you all know that the basic mechanism, this is the only selective cholesterol inhibitor. This is Niemann-Pick C1L1, which is present in the brush border of the small intestine. It prevents, it blocks this protein and thereby prevents the absorption into the liver. That is the chylomicron. So it is the selective cholesterol absorption inhibitor, and 2018 guidelines says this is the first non-statin alternative, and for high-risk ASVD patients, there was not much trial supporting this. So it was not in the limelight, but now after the IMPROVE trial, this has taken the main second line of treatment next to statins. And this is said. So the thing is, upon the absorption, it gets into the active phenolic glucuronide called ezetimibe glucuronide. This active metabolite is highly protein bound with a half-life of 22 hours. And it is mainly excreted in the feces, 70%. No dosage adjustment is required in hepatic and renal impairment. The trials, there is with it, you're using as a monotherapy, there's 18% LDL reduction. If you are using with statin, it is 25% reduction. even with high dose statins. This what? The SEAS trial was not much supporting initially. SHARP trial came, that the MACE. This Improve It is the big landmark trial which prevents 13% reduction in MI and 21% reduction in ischemic stroke with follow-up, and also the reduction of inflammation. And safety of ezetimibe is initially the SEAS trial was saying there was some incidence of cancer, but that was disproven by the big trial SHARP It and Improve It trials. And another very important is no interaction at all with any statins or things. LDL apheresis, to finally conclude that, as this is done mainly in patients with familial hypercholesterolemia, if they have a basal LDL more than 500 milligram in spite of statins, or if the heterozygotes with more than 300 milligram, or the heterozygote with cardiac disease with more than 200 in spite of statin therapy. It is extracorporeal, done weekly or bi-weekly, and the reduction is almost 50 to 60%, and the reduction reduces with future apheresis. And the problem is with venous access, hypotension, infections, and reduction of iron deficiency and all. So this is the final trial, final slide, which concludes all the things. This ezetimibe is the cheapest drug, 10 milligram orally, 18% reduction. Alirocumab subcutaneous, 50% reduction. Evolocumab 140 2 weekly or 420 4 weekly, 50% reduction. And bempatoic is ACL lyase, 21% reduction, 180 milligram. And inclisiran is latest, which has a 300 milligram and is given on 0, 3 months, and every 6 months. The reduction is somewhere 50%. But to surprise, this monoclonal antibodies are little potent than inclisiran in reduction of LDL. And thank you.
Any questions?
Do you use statins apart from atorvastatin and rosuvastatin in your practice? What is the role of pitavastatin?
Sir, for any secondary prevention of ASVD, I use aggressively atoro or rosuvastatin. If I want to put a primary prevention, my passion is pitavastatin. Because one advantage of pitavastatin is rosuvastatin and atorvastatin said to increase slightly the sugar levels, glycemic levels. Pitavastatin is a one wonderful statin which slightly reduces the glycemic levels or does neutral. And so in the primary prevention, if you want to start, you can start with 2 to 4 milligrams.
Thank you.
But I think one issue is we don't have any good trial data with pitavastatin. Research-wise, okay, it could be right, but we have such a lot of, volume supporting atorvastatin and rosuvastatin in primary prevention. The data with pitavastatin is very, very minimal. And another point, bempedoic acid, the most important side effect which we have encountered is increase in uric acid. In fact, some people develop 2 milligram, 2 to 2.5 milligram increase in uric acid. Because that I think is the real problem which we have encountered. Other problems are all tendon rupture and all I have not seen.
And most of these non-statin treatment, they are even more effective in the company of some small dose of statin. In other words, if given as a monotherapy, drugs like bempedoic acid, ezetimibe, etc., are not as potent as when they are combined. Let's say 5 milligram of atorvastatin. If you are forced to give these drugs as a complete alternative, they are not that very effective. In the company of statin, it comes to nearly 25 and things like that.
So even the recommendation, you should never start these as monotherapy. It should be either a fully intolerant statin you can start, otherwise it should be with high dose statin or moderate intensity statin. These should be started.
Sir, should we continue the same dose of cholesterol drugs if the cholesterol level come to normal, sir, after cholesterol levels come to normal?
Yeah, definitely. You have to continue the same dose. If you reduce the dose, there is a chance, or you can do it after 3 months, 12 weeks, you can find it out. The goal is, see, initially they said LDL less than 100, less than 70, now less than 50, very high risk ASVD. So you, depending on the patient, whether he is a very high risk ASVD or medium risk, The target should be achieved with LDL. It's not mere starting 20 milligram atorvastatin and forgetting. You have to do it first at 12 weeks and then 6 to 12 months.
One question, sir. The maintenance dose is same thing you have to continue for further periods?
Yes, sir. If you are able to achieve the target, you can maintain the same dose, sir. If you are not able to achieve it, you can
Increase,
up to it.
step up the dose.
One more question, sir. LDL apheresis, is it done in your place?
No, we are not doing.